and thank you for having me. So today we're going to talk about improving lives, reducing costs, and simplifying decision-making using an enterprise pharmacogenomics program. Really what we're going to talk about are a few things, including personalized medicine and genetics, and how those impact the entire system. Everything from employers and payers down to healthcare providers and the patients themselves, the important part of all of what we do. First, I'd like to talk about things that a lot of us already know and talk about. And that's, why is this important? It really is a financial and health burden on society these days. Prescription drug spending has exceeded $300 billion a year since 2015. Adverse events, those side effects that we all have heard about, whether they're ourselves, our parents, our friends who have been on medications, those adverse events actually cause other issues, emergency department visit, hospitalizations. It's not always headaches and belly aches. Medication errors actually occur in 3.8 million inpatient admissions and 3.3 million outpatient visits a year. And unfortunately, there are a significant number of deaths attributed to medication errors and adverse events that we would talk about. But we can impact this and change things. And one of the statistics that we hear about, and we realize why making adjustments here are so important, is that 1 in 4 Americans take 4 or more prescription drugs at a time. Now, this equates to a large pharmaceutical burden and polypharmacy. That's the number of meds that a person is taking for people taking those medications. And this is higher healthcare costs, drug interactions, those DDIs that we talk about in the clinic, medication non-adherence. Those are people that don't want to take their medications because of certain reasons, and it could be those side effects and other reasons. Decreased functional status, and even geriatric syndromes. But in all of this, your DNA really matters. So a drug can be toxic but beneficial, toxic and non-beneficial, non-toxic beneficial. This is the same diagnosis and the same prescription from patient to patient. And as we talk about personalized medicine and personalized prescribing, we now have the opportunity to use tools like pharmacogenomics and genetic testing to help with that prescribing. So rather than doing trial and error prescribing like we have over the last, many centuries, we can actually check ahead of time in silico on a computer using genetics, whether a drug is going to be helpful or not. But I do want everybody here to understand that DNA is not enough. You also have to have a really good understanding of the other important issues when doing prescribing. And these are things that our pharmacists are already thinking about usually, right? We're talking about drug-drug interactions. We're talking about contraindications. We're talking about anticholinergic burden, which is something that describes the CNS depression that one might have. I often describe this as the Benadryl effect. It dries out a person. It causes them to be lethargic. Sometimes this is what an older person might regard as, oh, I'm just getting older, right? But we realize it's their medications, these geriatric type syndromes. It's the #1 cause of slip and falls in the elderly. In our active working population, if you're a bus driver or a mechanic working on a warehouse floor, you want to make sure that this anticholinergic burden is dealt with appropriately. We also want to look at black box warning on FDA labels, things like geriatric and pediatric warnings and Beers criteria. All of these are important. Lifestyle warnings, the things that we eat and drink, like alcohol and grapefruit juice and leafy greens, these all impact how medications work. So I'm not a huge fan of the stoplight type red, yellow, and green that one might see in some typical pharmacogenomic reports, because it's not just pharmacogenomics. Just because your genetics say that you're okay to take a specific medication, there might be other reasons not to take those drugs. And there really is a huge cost to getting this wrong. You have adherence, appropriateness, and adversity. Now, it's easy for us to think about this on a patient level, but we want to think about this holistically. How does the system handle all of this when it doesn't go right? What is the cost of getting it wrong? And what we know is that hospital admissions go up, home health visits go up, even the number of laboratory tests go up when all of this MA3 issues are not contained. And so what we want to do is get this right. And we see when you get MA3 right, you improve everything from patient satisfaction and quality of life issues, their overall health, but also their use of medications. You also see a reduction in adverse events. You see the costs to medication and pharmacy claims, and total healthcare costs come down, and all of those things that I showed in the previous slide. Emergency department visits and hospitalizations go down. The number of slip and falls decrease. And so really, when we think about this, we're addressing the quadruple aim in healthcare, or the triple aim, depending on how you think about this. And this is considering healthcare workers, right? The care team and their well-being. We want to be able to address all of these prescription issues, these personalized medicine issues, without burdening the healthcare provider with being a geneticist or being a pharmacist or being an expert in all of these spaces. We want to empower them to be able to take all of this information and utilize it quickly. The same is true by improving quality of care. We want to address each patient's goals to improve safety and efficacy. And every patient has a different goal, right? Whether it's playing with the grandkids, walking the dog again, or just feeling better and not having headaches. We want those better outcomes and the improved population health. This isn't only individual to individual. We want to see our older population feeling better. We want to see our active well population doing better as well. It improves public health overall. And of course, we all want to reduce and lower costs. So what I'm going to talk about today is an entire program that goes from population analytics, this idea of who's going to benefit the most. Take this. Now, I'll be the first to tell you, I think that eventually in a few years or maybe even sooner, we'll all know our pharmacogenomics. We'll know all about ourselves and our genetics, and it'll be on our smartphones, or we'll carry a USB or some kind of stick along with us. So we have that information with us all of the time. But I think to better society and help with the public health issues right now, we really need to address these issues and those people who are going to benefit the most first. And to be able to do that, you have to have metrics on top of things and understand the population analytics. And so in any program that you're considering to do and roll this out to a large population, I really recommend that population analytics to understand, who am I working with? What does my population look like? Who's going to benefit the most from this? That should be looked at as a primary source of information. Then we have member engagement, and it never ceases to amaze me, the really smart, intelligent questions that I get from folks who are not geneticists, not pharmacists, not physicians and prescribers. The people, the members that we're enrolling in these programs are very interested in their health. And so part of member engagement is education and making enrollment as easy as possible without having to jump through hoops. The genetic testing at this point has to be cost-effective and comprehensive and specific for the drugs and genes that are actionable in the clinic. Medically relevant and clinically actionable is a term that I often repeat over and over and over again, because I want everybody to understand that we don't want to burden our healthcare providers with just informative pharmacogenomic information. It's not helpful. We all know about alert fatigue. If we're just throwing informative information where references need to be read, we're not going to get the outcomes that we're looking for in these programs. And so genetic testing needs to come with very, very specific information on how the information can be used in the clinic. And this comes down to the fourth box that I have here on pharmacy medication therapy management review or comprehensive medication management. The idea is that our pharmacists are already thinking in this way, and they're already used to incorporating genetics with lifestyle, with DDIs and anticholinergic burden and Beers criteria and all of these other risk factors that I mentioned earlier into one conversation. And by empowering them with decision support tools, good clinical decision support tools that allow the physician to, or the pharmacist to see all of this information in one place and make good, well-informed, thoughtful decisions and communicate that to the prescribing physician. All of a sudden, we've got an entire program that runs from understanding who to test, engaging those people, testing them and communicating and making changes. And then there's a slide here or a box that I don't have that's the feedback loop, that once things are changed, understanding how that's improving the health of both the system, the healthcare provider, and the patient themselves. So I'll give you an example of how we at Coriell Life Sciences have rolled this out. We have a decision support tool called GeneDose Live. And in this system, the pharmacists can go in and see all of the medications that the patient is taking and all of those risk vectors. And it's boiled down into this beautiful, easy to understand chart so that the pharmacists can do triage very quickly. They see a large bar. The larger the bar, the more the risk, and they can see where that risk stems from, whether it is genetic or another piece of information. But what's really powerful about a tool like this is it provides the pharmacists with the ability to, in silico, audition alternative medications. They can review the medication that their patient has taken, but also on the computer, test which ones are going to be more safe and more effective. So let's say a patient was taking an antidepressant, a tricyclic antidepressant. There's something like 74 medications on the market in the US, both over the counter and prescription, and even supplements that people can get at their local drugstore for use as antidepressants. In the system, if you see a risk for the antidepressant, you would then be able to say, well, I need to change that medication. You would click on that drug and it would give you the other meds in that same therapeutic class and would show you the risks involved in changing the medication to something else. So for each of those 74 alternatives, you would understand the potential risk. So now we don't have to give the person that medication and wait 4, 6, or 8 weeks, which is the length of time it takes for a patient to see the benefits of an antidepressant. We don't have to wait anymore. We can increase the chance of hitting the right medication by using genetics and these other risk vectors. This risk analytics engine allows the pharmacist to see all of those risks and which patients are going to be ill-suited or which pills are ill-suited for a patient. And again, like I said before, it shows you which drugs are more or less risky. We can also include formularies from different hospital systems in here and really include the other risk, which is pricing information. So we include things like the generic price and the brand name price. If a drug is too expensive and the patient doesn't take it, it's as good as, you know, it's no good at all, right? We want our patients to adhere to the meds that they're being prescribed. But we also want to report this to the pharmacist or to the prescribing physician in a way that they understand it. And the medication action plan that comes out of this system provides results on which drugs to remove, which to add, and which to change. And that could be dosing, time of day, route of administration, and then which drugs not to touch. It boils down all of this information. And for polypharmacy patients that might be on 15 medications or more, it makes it very easy to have the conversation with the prescribing physician. So in our remaining few moments here, I'd like to provide some insight and a case study. We've been working with the teachers' retirement system of the state of Kentucky for a few years now. The average age of their members is 74 years old. They have about 37,000 retired teachers as part of their MEHP program, which is their Medicare eligible healthcare program. In that, there are 7,000 retired teachers who are over the age of 65, and they join at they're over the age of 80, but they join at the age of 65. So in a population like this, you'll soon see the benefit of enrolling them as early on as we can, because they're part of the system for so long, and genetics don't change throughout the lifespan of the member. So while genetics stay the same, these other lifestyle and drug interactions and indications and diseases that a member might be suffering, those change. And that's why a program that keeps this stuff live, things like GeneDose Live, that allow you to change that. You might be pregnant now, but not in 9 months, right? You might be suffering from oncologic issues now, but not in 3 years. And so, whereas the genetics don't change, these other surrounding issues do. So a system that allows you to take account of all of this is really important. Interestingly enough, there are 2 members of their group that are 108. One of them may have had a birthday, might be 109 now. But of those 37,000 retirees, they're aged 65 to 108. And we enrolled so far voluntarily. They've been introduced to the program, provided educational material that tells them about the cost, that tells them about privacy and all of these details that they've been interested in. And we enroll them, and we've enrolled just shy of 30% of that population to date. Early on, even before we started enrolling, we understood that a lot of these members are taking medications. 15 medications was the average number of prescriptions that members were taking. And these folks aren't outliers. The US, we see that across the entire population. And it might not be surprising to you that 75% of them had high blood pressure and heart disease. They had high cholesterol, pain and inflammation, other comorbidities like diabetes and depression and pain management issues that we all know are an issue in our elderly or our actively aging population. As part of that public health analysis at the very beginning, we realized that 83% of those members were already taking a medication known to be impacted by genetics. Let me say that again. We know that 83% of those folks are taking at least one drug where pharmacogenomic information is going to be impactful to their prescribing. So this is a population where pharmacogenomics and these other risks could actually be really, really helpful. And we know, based on the drugs that they're taking, everything from the drugs that treat depression to pain management to cardiology to gastroenterology, we know that they have misdirected spend, and these drugs should be changed. So they're not going to see the financial return of just taking a person off a medication, because every time we take somebody off a med, we probably need to replace it with something else. Now, what we actually see in real life is that over time, people start being on fewer medications once their meds are handled better. And those are drugs that might be dealing with those side effects. Over the course of time, when we did our first and our initial evaluation, we realized that there was a huge impact of pharmacogenomics on this population. In fact, about 64% of the medication action plans resulted in recommended changes to plan. So out of all of these members who enrolled, the 9,000 of them, even when we were looking at several months ago, a large number of them were benefiting from having a review by a pharmacist. In fact, the top 5 most frequently removed drugs were removed specifically because genetic concerns. And this is dictated and noted by the pharmacists in the clinical decision support tool itself. And so quickly, I want to talk about the outcome of this program. And first of all is the reduction in these medication, these MA3 related risk incidents. So I talked earlier about the MA3 incidents, and these are the CPT codes, or rather the ICD-10 codes, and the indications, the diseases and the things that happen, the events and the incidents that happen to folks that we know are impacted by pharmacogenomics. And through our evaluation, we saw a downward trend in the utilization of the healthcare system following MAP delivery over the course of the time afterwards. And that was there was a 13% reduction in those MA3 events. So hugely impactful. Even more exciting to the system is understanding that cost reduction. So folks that had been enrolled since January of 2018 were coming on 3 years for some of these folks as they rolled out the program. And after the maps were delivered, we saw a 14% reduction in the cost to plan spending over the 16 months following MAP delivery. Now, what's interesting and probably not surprising to most of you, our internal control group, this is people in the system that had not gone through pharmacogenomic testing, they had not received a medication action plan, their physicians and pharmacists were not involved. They actually had an increase of about 3.2% in their cost to spending. The other metrics of success that we saw in this program are wrapped around the number of recommendations accepted by prescribers, right? These are naive prescribers. So our ability to communicate changes in the plan well, and including pharmacists, that number is really impressive. Early on in these programs, one might imagine that if you just have pharmacogenomics, the recommendations aren't always accepted by prescribers, but we've seen that number go up over time, and by including the other risk factors, and by including good communication between the pharmacists in our team and the prescribing physicians. We've also seen a reduction, 11%, specifically in pharmacy spend. Okay, so you've got all of that. Total healthcare costs have gone down. The pharmacy spend has gone down. And we've also seen a reduction in hospitalizations. We've seen a reduction in emergency department visits. And we've seen a 27% reduction in slip and falls. I'd like to think that everybody here knows somebody who's affected by medications that just don't work. And wouldn't you like to help those folks when those medications don't work, or if they're harmful, knowing that there's ways to do it using genetics and making that a complete story using these other risk factors that are impactful when considering the health and wellness of our society. Thank you so much for your time, and I look forward to hearing your questions after this.